January. I have been in practice for 13 years and I'm new to the UMass system. But I'm not new to, OBGYN work and then working with doulas. The goal of the program is really around helping to um, improve the experience and outcomes of Black birthing people. Um, and that's really important to me. I think that as I look at the opportunities that there were for how can we do better when it comes to maternity care. Um, Obviously, my own experience brings me to this work as an OBGYN, also as a Black woman, also as a mom. So the overall program goals and objectives are to address this severe maternal morbidity or, decrease the bad outcomes within Black patients at UMass, increase the community and the OBGYN department of the Maternity Center Trust, um, looking at the perinatal workforce, really trying to increase diversity in the perinatal workforce, and then obviously providing doula care. Doulas are amazing. You guys are great. And there are things that you can do that OBGYNs just can't. And the point is that you can go to the next slide. When we look at the big picture of where we are today, this data is from January. Severe maternal morbidity, we all hear about deaths, but near misses, severe life-threatening maternal conditions. Of the states that report outcomes, Massachusetts is second from the bottom. And so I think that a lot of times when you live in the Northeast, you think like, well, terrible outcomes are happening in, places with less resources, places with maternity care deserts. Yes, they are, but when you're talking about bad outcomes, they abound. New York has really bad birth outcomes, California as well, Florida, Massachusetts is second to the bottom. And then we just aggregate that data and we look at severe maternal morbidity for Black non-Hispanic people, you can see where it's an outlier. Um, and in Massachusetts, when it's disaggregated by race, we're at the very bottom. So we have nothing but nowhere but up to go. And this is very recent. This is as of January. And so I have said to myself, our team has said, what would happen if patients with the worst outcome receive the best care that we can offer? So again, coming from a place of humility, I cannot, as an OBGYN, even with the best of intentions, I cannot fix this problem, right? This is not because of something that's wrong with Black people. It's going to take many hands to do the work of dismantling racism, which is a root issue of racial health disparities. It also takes so much to support families. We can go on. And if we take out like a kind of a public health perspective, racism as a public health crisis, this is something that's been noted more recently in the health outcomes literature. And even right here in Worcester, where you live is more indicative of your zip code than where you live is more indicative of your life expectancy than anything else. And so if we think back to the historic redlining and how property values, basically you've had uh, a lot of banks basically were not lending to Black neighborhoods, and you couldn't get this, and that's the practice of redlining. But we see almost a 10-year difference in life expectancy based on where you live. And so we have to do things very differently if we want to have different results. So over the last several months, I've gotten to know many of you. Anaya has also gotten to know many of you. And the Worcester doula community, there have been so many organizations doing great work, including Department of Public Health, including a company, Doula Care, like so many, there's a lot of energy around doulas, both in Massachusetts, other states. And it's been a real pleasure to get to know some of the local doulas. I see, thank you all for joining tonight. When we started to really look at, well, what is the perinatal workforce? And as I mentioned, part of the goal of the program is perinatal workforce diversity. Once upon a time, almost 100% of babies were born at home, or 100% of babies were born at home, and almost 100% of babies were born at the hands of Black women with granny midwives. And so when we look at the field of midwifery and how it is, how there's such little diversity, and similarly within doulas, it's not because people don't want to become doulas. This racism is really pervasive. And so we have to be intentional if we want to work against that issue. And so we've spent some time to really understand the landscape and who's out there, and then looking at program components. You can go ahead. So a big part of the program moving forward will be to continuously train additional doulas. And one of the things that we've heard from people is, they got trained and then they kind of sat waiting. And I think that as everyone was waiting for Mass Health to say how they were going to do this, it was probably a thought that the UMass program was going to hire several doulas that were going to be, part-time or full-time. But the way that Mass Health benefits have rolled out, doulas have to work directly with Mass Health and not be employed by a hospital, which there's pros and cons of both, but that's part of the way the program is developed is based on how the structure was developed within Mass Health. You can go on. So just doing a deep dive on the births at UMass Memorial, because again, this is the UMass Memorial Doula program. And so this is really looking at how do we look at the births that are happening in a target population, Black birthing people, and how can we provide additional support? We look at the payer mix and the race and ethnicity. And so for our target overall, for like 1 year, there's 481 births to Black people within UMass Memorial out of the 5,000 births. That number does fluctuate. We did like a 5-year look back, and some years it was 700. And also this is going to depend on how this is being asked, because I have been to hospital times and I've never been asked my race. I think there's an assumption that's made sometimes. And so there's room to grow as far as getting really accurate and meaningful statistics, but working with what we have. The majority of these patients in this racial group have a Mass Health coverage of some sort. And so looking at the Mass Health benefit and really trying to build a program around how do we use what we have. There's some philanthropy resources, and really try to make things stretch to cover the target population. You can go ahead. So if you haven't gone to this, go on to Google and just search UMass Doula. This is the very first link that pops up. I hope you've been on the program website. Please, please, please go on the website. If you're meeting people who are like, oh, I need a doula, I want a doula, even post it on your social media. Take a look around. If you have suggestions or comments, or you think, oh, you know what, this is something that's missing, this is something that would be great, we're happy to make changes on the website and make additions, but this is a resource kind of linking to other things, but also giving some general information about what a doula can do and the program in general. And then there's a doula request form. Right now it's hidden, and we're trying to get the web folks to put a bigger button so that people can act on it. That doula request form, anyone can fill out this form on the website. Our team receives them directly, and then we're working behind the scenes with some of the other groups at UMass to help connect patients who are not in the exact target audience. But this form can be translated into English, Spanish, Haitian Creole, Portuguese, and Twi. So just by clicking that select language, that translates the form so the patient can fill it out in the language that they're most comfortable with. And we chose those 5 languages based on the most commonly spoken languages in Worcester among Black people. You can go on. So we're also taking this on the road as far as providers, like doctors, midwives, nurses who are caring for pregnant people, whether they're OBGYNs, family practice, nurse practitioners. We've been giving a similar version of this presentation to show, hey, marketing is developing some brochures so that your offices can have this, and also to have it available at community events to let patients know doula services are available. Mass Health covers doula services, that the UMass program is there and what our focus is, and then how to get more information. Also, if you have a group, team, or that you're on, or a community organization that you work with, and you think, hey, it would be good for them to hear some version of this, whether it's just about doula services that are available at UMass Memorial, perfect. We would be happy to do that by Zoom or in person. And then within Epic, so UMass uses Epic as a electronic medical record. There's an order for ambulatory referral for complex care management, doula services is on there. And so doctors are getting this information of doula services are available to your patient. Please talk to your patients about it. And so patients may come to this realization or, requesting doula services, but then also doctors are requesting the support for their patients. You can go on. This is what it looks like in Epic. There's actually a doula button. And so there's a lot of provider education that's really needed. And again, from our program perspective, sometimes there can be a lot of friction within, a hospital system and doulas, and we're really trying to be intentional about how we build the program. Being a hospital-based doula program, it's not, again, to say swallow people up and make them do what everything the hospital wants to do. We have nowhere to go but up. We are performing horribly when it comes to our outcomes for severe maternal morbidity overall. And then again, we were second to last in that, and then very last when it came to Black birthing people. And so really from a health system standpoint, really trying to convey that to our hospital administrators and OBGYN colleagues and all those providing care to understand that we are not doing a good job. We are not delivering, although we have the best of intentions. How can we partner meaningfully with others in this space to have better outcomes for patients that we care for? Go ahead. So there are job postings. We'll put the links in the chat. If you have questions about the roles, we will be hiring a doula program coordinator. Anaya has been wonderful, and I will be going to medical school in the fall. Also hiring one full-time and one part-time doula. Our team, the role that we're really providing, and we'll get to this as well, is more, so being hired as part of the doula program team is really to work with myself and Anaya until she goes on, working together to have the maximum impact of this program by connecting as many patients as we can in the target population to doula supports. So it's not that you would have, 20 patients that you would be, on call for deliveries all the time. It's a lot more care coordination and connecting people. You can go on. And so when we get a form that's a patient who says, I want a doula, they're getting a phone call. And so we can understand a little bit more of what their needs are, where they're getting their prenatal care, what are some of the concerns that they have around childbirth and what they're desiring as far as support. And then we try to help them to convey to us, like, what do you need as far as language? Do you have any preferences? Even like what part of town do you live in? Where you're getting your care as far as like, do you want somebody that's going to be able to come with you to mostly visits? Do you really want somebody who just kind of all of the things that you would normally do when you're talking to a client to figure out, is this a good match, a good pairing? We take that information to you all, Doula Collective, and say, hey, who is still has room for patients with this due date? If there's a language desire, we've had a couple of inquiries thus far where patients has just asked, I just need support. And so really kind of we put it out there to say who's available and make a connection with the client. We'll connect you to a view by, go ahead. So that intake form is done by the patient. Our staff then gives a call to get additional information, get the context. Also, because our staff will be working within Epic, once we are a little bit further along with hiring, we'll be doing some screening around social determinants of health to really maximize all of the things that within the health system that patients can get. For example, I don't know if anybody here knew that if a patient has Mass Health and their provider or their is part of UMass, the patient who's pregnant can have $80 a month for groceries, additional support. There are all of these different programs and things that are available, but the amount of hoops that patients have to jump through to get them are a little bit, it causes a challenge. And so that's part of what we want to overcome. It's just kind of getting the maximum support for patients in partnership with patients to take out some of the friction that there exists within the system. And so that's what our team will really do. Doulas in the community, well, if you have availability, you're able to work with patients. Really, it's just responding to, responding to those inquiries of, hey, are you available? Are you able? And yes, and then the connection, sorry. When you do provide support for a patient, if you there's documentation that's required from Mass Health in order to bill. And so we just ask that you're doing that and sharing some of that with us. Eventually, we'll want to do research on our program and how effective it is. But for now, we're really working out the kinks. Um, when a patient's admitted to the hospital, their chart's updated to say they have a doula. This is the doula's number. Please contact them on admission. Obviously, a patient will be working with you directly to say you're here, but we want to engage the whole care team as well so that there's not oh, after all of that, you know, this emergency thing happened and the patient didn't get a chance and you kind of were left out. That's not the goal. Because even that support, whether even if a patient goes to C-section, there's still support to offer in the postpartum period, or even in that process of C-section. So we're working collaboratively, and any feedback that we get from you all, we want to take it back and really just kind of work as and work as liaisons, work as intercessors, whatever term you want to use, but really trying to smooth out some of these rough spots. So Anaya.
Yeah. So with Mass Health comes billing. So like as a doula, we have to bill Mass Health on our own. And I've done the process and it's kind of, it can be tricky, like if you don't understand like what they're asking for. So another part of our program is to help the doulas that partner with us and who are our staff doulas to help them to learn how to bill with Mass Health. So this is what the website looks like when you have to log on, and you can go in here to check if the patient is eligible for Mass Health, and you also go in here to bill for each appointment that you have with the patient. So based off of my own experience, these things that I've circled in red, for example, are the like some locations that are approved. So you can say you did your appointment at patient's home, you did the appointment inpatient in a hospital or on campus for outpatient hospital visit. I've tried like a telephone or office visit, and those didn't work. They got kicked back. And then for the diagnosis codes, there are certain codes that you have to use for each trimester. So if you're in the first trimester, the ICD-10 code that you'd use is here, the Z3481, a Z4382 if you're in second trimester, or Z3483 for third trimester. Additionally, there's a different service code that you have to use depending on the length of the visit. So if it's a 60-minute or if it's below 60 minutes, then you use this 99600 code. But if it's 61 to 90 minutes, then you use the same code, but you have to put TF in the additional space. And then there's a different code for labor and delivery support. Also, you can charge up to $150 if your visit is 61 to 90 minutes, but you do have to take it into account that no matter how many visits you do, Mass Health only pays you essentially for a max of $800 for perinatal appointments outside of the labor and delivery support. So if you do try to do like 3 visits that are 60 minutes plus, you can't do like 5 other 60-minute visits because they will kick it back because it's over the capacity, over the amount that they allot. And then each delivery that you support is $900.
So Adwapa had a great question. So if we're thinking about this, the 2 staff doulas for UMass are salaried positions. They are welcome to, so salary positions, 40 hours for the full-time, 20 hours for the part-time. Again, the role is mostly that intake and connecting patients. We also are doing childbirth education and breastfeeding support. And so it'll be a lot of facilitating of those groups. And so the staff doulas are welcome to take clients outside of the program, but they're not going to be, so like if we get that's the role of the staff doulas. And it's in the description. I feel like, I know it's not, partly of this again is how the program developed is based on how Mass Health, a hospital cannot bill for doula services. So it's not like when I see a patient, I'm, I'm seeing patients in my office and then I do my notes and do the care and then the hospital bills for services and they get paid. Eventually, my paycheck is the same no matter what I do, every 2 weeks. For the doulas, that's correct. They are not, it's not, you have 6 clients this month for how many births you're supporting. We have to run the program. And so running the program is just that. So if the staff doulas, those 2 people, they'll be running the breastfeeding support groups and doing those intakes, which includes social determinants of health screening and working with the teams to spread the word on the program, helping to do even like in the offices, helping patients who are seeing providers at UMass to know, hey, doula support is available. This is what a doula does. So it's a lot of patient education, interacting with people. It's not sitting in an office, just like kind of looking at spreadsheets, but it's not doing, supporting 4 and 6 births a month. Um, Birth support for the staff doulas, those 2 people, the one full-time and one part-time, will be more as an aside, of your own accord. And so the goal of this orientation is just again like that, understanding that to make this program really successful, it's that all of you who are out here doing doula care in the community, that we're able to connect you with more clients who are looking for your support, but maybe can't navigate the Mass Health website or their insurance. Maybe they have Blue Cross Blue Shield and it doesn't have doula benefits. Like I said, we do have philanthropy funds, and so we'll match that same Mass Health rate. And it's really just, so in order to do that, so if you have a client who they're not Mass Health, and they have another insurance or they don't have insurance, whatever the case is, that it's not going through Mass Health. Doulas who are participating will have a contract that says, if you all send me, you all meaning UMass, send me a client, you're gonna pay this same $1,700 for the birth in totality, with that antepartum, the labor support, postpartum. So you would have, um, that in writing to know. And then you have also like, so the clients, you're never having to go, if we are sending you clients, you're not going to that client to collect your money. You are either going to Mass Health and we'll let you know this person has Mass Health. So, you'll be billing to Mass Health, or this person doesn't have Mass Health. You will be getting paid through UMass. I hope that answers the question. And anybody can feel free to come off of mute, ask your questions. We really want this to be interactive. And I know it's not, it it has evolved over time based on the environment that we're in. This all happened December 8th with and I was on the Zoom. I don't know if others of you were on there when they said like hospitals can't bill for doula services. I think the point of the Mass Health program, the way that they've implemented it, was really to look at, there are doulas out in the community who have been working and supporting families and they don't have a way to get compensated, and really looking at how could this coverage increase doulas in the community's ability to be paid for their work that they're doing on behalf of clients and families. What other questions?
While you guys are thinking of questions, I put the job descriptions in the chat for all of the 3 positions. So feel free to share them.
So for anyone, like, what's your client load right now, or who's ready to, like, they want to get referrals? Just kind of what's your scenario right now?
I'll start. This is Miriam. How are you? Can you hear me?
Thank you. Yes, we can hear you. Doing great. Thanks.
Right. Yeah, thank you. So I just enrolled with Mass Health and it's definitely looking to work in the Worcester, Shrewsbury, and surrounding areas. I'm with a company doula care, but also independent provider, and I did my doula training with Forenza Holtz, which with the REACH grant, which is to be able to help women in this community. So I'd be interested. I actually did the application. I could not get past the, I think education. It did not let me input my where I did my university training. So I was not able to get past that point. So if I do, I'd be interested to complete the application and to see where it goes from there. So I'm not sure if anybody else is having that difficulty in applying.
If you,
Yes, this is Florence, and I did have the same problem to apply.
thank you for
Yeah.
that feedback, because we
Yeah.
haven't gotten, so I guess one thing is for that clarity on, the roles. I think that if what you're wanting is like, I want to support patients, as many clients as possible. I want to be more full in my doula practice, then this is exactly that forum, so I like understanding, hey, I'm really full for July, but any other month I can take people, or I'm wide open, please just, send people my way. We pretty much, this is the perfect forum. If you're like, I want to be supporting families, that's the majority of what I want to do. I think for the role, a lot of it is that care coordination. And so I will, if you have, feel free to send a direct message or put it in the chat if you've applied and you haven't heard anything, because I wasn't aware of, uh, like we're working closely with the HR, the talent manager person, and hadn't heard of, like, we're like, oh, there's not a lot of activity going on these jobs. But again, the job, I think if you are wanting to be very busy as a doula supporting families, those jobs are actually not it. It is being a part of kind of the network. And so I think that that's the point of this forum, to really convey that. I think it's hard to get that across. I know I have met with some people who it was kind of surprising, like, oh, well, that's not really what I want to do. That they more want to be, hands-on with clients and families, as opposed to like coordinating the care.
I know the other time you guys send a message send a text and say you guys have received, somebody said we have received the first client. So I was wondering, are you guys still open to send clients our way? And I think you guys asked the question whether somebody was living in Fitchburg, but nobody answered because most of us live in Worcester area. So are you guys having clients that live in the surrounding areas instead of Worcester?
That's a great question. So yeah, so what the ideal would be that if we have like kind of a email list or a group, kind of to blast out to say, if a person has not really given much, like we're working with a client to say what our first inquiry was for a patient who lives in Fitchburg. We'll be delivering at UMass Memorial, and they see a provider at Family Health Center of Worcester. So even though the patient lives that far, this is where they're getting their care and where they're delivering. And so that kind of process, as we have an inquiry, we're going to kind of reach out. One is understanding what the person's payer source is, or what their needs are as well. If there's any language needs, et cetera, and then putting it out there to the doula community based on the preferences and whatnot that they've given, to see who's available. And so that's a major thing of just being able to kind of know what's your volume and what are you able to do, and then responding, and then we're just matching. And so things that you can do is making sure that we have your information so that we can be a part of that. When you get the bat signal, And then like, what is your availability? So if you know that you're really overcommitted for July, that's good for us to know. So then if there's a due date that comes in for July, then we don't necessarily have to um bother you about that person. Um, but yeah, so keeping us up to date on what your availability is, and then just responding as the inquiries come in. Also, really sharing the program, I think, is another thing that's just so helpful because I think a lot of times, for example, you may get a person who comes to you through Instagram or through your website who wants doula support, but they're like, well, how am I supposed to pay for this? Like you have your rates on your website. If you find that like, you know what, this patient is delivering at UMass, like send them to the website and hopefully that we can, connect them in that way.
I also put in the chat an email that you can send information to if you have any questions, to send your availability and any problems that you may be having. It's doula@umassmemorial.org.
Hi, so my name is Crystal. I just want to thank you guys for taking the time to answer questions for us. Um, so I am not a doula, but I do work as a homeless provider, and I've been in that space for quite some time. So my question is, looking at that that billing chart that you had, it didn't seem like you guys build towards shelters. Do you foresee like there being like support groups or, you know, um, education for persons who reside in shelters in the future?
Yes, I love that point. So if we mentioned, and I'm not sure which, or you're saying the setting that you would put the billing for?
Right.
Okay. So more to the question of people who are residing in shelters and are pregnant or postpartum, providing doula services, absolutely. And the so one thought is just immediately if you have someone that you are working with who's in that setting to just getting to the form and filling it out for that support. The most thing is an email or a phone number that the person can be reachable at to connect with them to send and say what support is there. Another thought is in our program, once we have our full staff, we'll be doing support groups in the community. And so locations and spaces and the ideal timing for childbirth education or breastfeeding support groups. We're open. I think a major thing that we realized when we kind of looked at the landscape was, a lot of what's offered is like during working hours, and during the week when people kind of need things after work or on the weekend. And so that's part of how we're building the program to say, look, we're going to do childbirth education. Something's going to be available on the weekend and something's going to be available on the evening, to really be able to support people where they are and in the time that they actually need it. And so if you think that in a shelter there's a large population or that would be a good place to do a support group, we're totally open to that as well. As I said, right now we have to put our staff together, but that's another thing that the staff doulas will be doing, is really facilitating those groups.
And I also wanted to clarify because I think you were talking about like the different locations that we can select for billing. And that's a mass health thing. So I'm gonna speak with someone to see if, like for example, if they have, I don't recall seeing homeless shelter on the as an option. Oh yeah, I see homeless shelter on here. I haven't tried that option per se, but I'll try it to see if it works. But I don't think that should be a problem uh, with billing for someone who's in a homeless shelter, especially if they have mass health.
Thank you.
Yeah, and so the listing is not to be, these are the places where care can be provided. Care can be provided in any setting. And, just even in my experience with doulas, you may have someone that you're supporting and you're texting with them, every 3 days. Well, how do you then put that into a bill to say, how am I supposed to get, like if we're mostly texting until, this one or two visits in person and then there's the delivery, we're gonna want to work with you, especially with people that we send to you. But even if you're just like sessions like this, where it's like, I have questions, how am I supposed to do this? because every birth that you support, you should ideally be getting that $1,700. And so it might mean that you have to plan it out to say, okay, if the patient came to me at this point, I need to bill. And with Mass Health, you have to bill every 90 days. You can't like wait all the way to the end to then say this is the global pack. It's just, it's different. If I had, as an OBGYN, if I had to do all of my billing myself, I wouldn't do it. That's the first thing. So we're seeing how it is, that it's difficult, or there's some challenges. It's not insurmountable, but I think it's like kind of asking people to speak a different language than what is the language that they're using on a day-to-day basis in their work. And so we want to take some of that. We're trying to do some of that legwork and then whittle it down to say, all right, this is what we found that actually works. You know, almost like if we have like technical assistance sessions to just say, if you have a question, and I know that Mass Health does it as well. We've gone to some technical assistance sessions and they were somewhat helpful. But yeah, we think that also just building a space where you all can help and support each other, and then if there's opportunity for us to help and support you all as well. Any other questions? And please, like, this is you're welcome to ask whatever questions here. Or comments. Like, has anybody supported a birth at UMass recently? How was it?
Like shot him. And we welcome honest opinions.
Sorry, I'm having dinner with my little one. Okay, now she's heard me talk, so she wants to say hi. But yeah, I've had
Hi.
yes, so I think my last birth was a couple of weeks ago. It was a preemie, came early at 32 weeks. Baby's fine, mommy's fine, baby's in the NICU, but it was quick. And she ended up having a C-section, and her partner was there, and I of course couldn't go into the OR. I have been allowed in the ORs at some point at UMass, so it's just one of those really frustrating time as a doula where you have somebody who is having a preemie baby, who is already scared, who everything is going quickly, and as a doula I can support her at a time when she absolutely needs me. So how are we going to ensure that doulas are still respected in the hospitals? Because like I said, there are a lot of times I've been in, and there's also a lot of times where I'm told it's the policy. So how are you guys going to ensure that we can still be at places where clients need us, where it's in triage, where they're scared because things are happening, it's taking forever for them to get into the room or in the OR or in the PACU?
Yeah, no, that's a great question. Working with the policy team, because one good thing, which is current state, that the employed doulas would not count as a visitor. And so that's one, like a workaround. That's not a great workaround, but it's a workaround nonetheless. Because again, like they're hospital employees. So for example, if in this immediate time frame, while the policy is what it is, which is that a doula counts like an outside doula, not employed by the system, counts as a support person. So it will be either the doula or the partner in the OR. We're working to change that. And then also looking at how quickly after the OR would a doula be allowed back, for example, in the recovery room. I think it's very important, right, to be able to just have that support as immediately as possible. And you bring up the point I want to specifically ask about triage, because those special times, lots of decisions are being made, or the decisions that were previously made are being asked. And so really supporting patients in their ability to exercise agency and say like, well, this is what my plan is, or this is what I've decided on. So yes. Now, like I said, for the immediate if you have a client, so let's just say a month from now and we're staffed and you have a client and the patient's going to the OR and like you say, this person just really needs that support, those staff doulas would be able to maneuver some of those places in the hospital in a slightly different way than doulas who are not employed by the system, but we're working to change the policy. As I said, I have experience in other systems where we basically it was flat out, doula is not a visitor. These are the requirements. You know, that so we had, 6 people could be in the hospital and anytime, any place where a patient was, the doula could be there as well. And so that's the goal of where we want to get. And I know that we're not there right now. Thank you for the question. Pamela.
So this is Florence. So if, like you said, Akwaba saying you said, it's the hospital is saying it's the policy. Is it not infringing on the client right if you've been to a prenatal visit and the client said, if I'm going for C-section, I want you there, and you already have it on the client's birth plan? Will it not be infringing on the client's right?
So for the OR,
Mhm.
you have limited space and limited number of people available. And so if they have the policy. So if the client in their birth plan wants their doula, if the policy as it is the patient is allowed to have one person there. If there is an interpreter that's needed, that's either an iPad interpreter or an in-person interpreter. And so you can imagine that the space gets tight. As I said, the ideal state is that we can get anesthesia, the OR, infection control, all parties on board with having a doula in the operating room. As it currently stands, that's not the policy for the operating room and the recovery room. I'm going to specifically ask about triage as well. So I hope that answers your question.
Yeah.
Pamela?
Hi, I've just done a couple births. I'm from Boston area, and so I don't go to Worcester that often, but occasionally I get somebody out there. And so, I would say the obstetrician that this latest woman had was incredibly supportive, but I think it was the residents. They never identify themselves when they walked in the room. It's like everybody said, "Oh, I read your birth plan," but they kept asking the same questions. They weren't actually like acknowledging or following through. So she didn't want, she explicitly said she didn't want an epidural. They kept asking her if she wanted, they would just pop in and say, if you need an epidural. And so it was almost like short of being a hard, kind of a hard ass and saying, don't come in the room, which I didn't feel like I had the authority to do that, especially with the residents. It's like they pay lip service to the birth plan, but they weren't following through. She was harassed. It's like they asked her like 3 or 4 times about if she wanted an epidural, like if she'd changed her mind. It's like, no, she hadn't changed her mind. We'll let you know if she changes her mind. Right. And the same thing with like the monitoring. She wanted limited fetal monitoring, but to find that baby's heart rate, it always took 20 or 30 minutes. And somehow they couldn't find it. And so there's this sense of need to perform the medical kind of task as opposed to like they say they're following it. Oh, we know you don't want to be monitored, but they still needed that information. And it was a good 20 to 30 minutes each time they did. So I feel like, you know, I, I feel like compared to other hospitals I've like been at, there are there was progress there, and and I applaud you for that, but I felt like there still wasn't like the acknowledgement. There was a change of shift. So this is something perhaps to like bring up with the staff, but there was a change of she happened to deliver at 7:01. I blinked and there were 15 staff people in that room. Every freaking nurse on the floor came in, right, to like be, but nobody identified themselves. There were special care people in case of because of the meconium. There was the actual attending. There were residents. No, I had no idea who anybody was. It was not clear, from that. It happened in like a nanosecond. Everybody just flooded in, and there was no space to kind of clear the room. She opened her eyes and she looked around and she was like gobsmacked that everybody's in there. I don't think that's a usual thing. I think it was, and I don't think anybody meant badly by it. It was like both change of shift and excitement about, like seeing a baby come in and stuff like that. But it didn't follow like her birth plan. So those are, I would say that maybe that's something to pay attention to.
Yeah, I appreciate that. I think, one of the things that just kind of pulling out some of what you were saying, it's not just to say, we know you have a birth plan, right? It's like, what are the salient points that we're trying to accomplish or achieve, and having that be part of what's passed down from team to team, so that, if the two major, I mean, there can be lots of details, and there's various ways, and everybody has kind of their way of how they do birth plans. It may be where there's a lot of details, and maybe where there's more of an overarching kind of concept or idea. But I think that having more than saying that it's been read, having it be reviewed so that there's clarity in the team when the patient is admitted, perhaps, is really kind of like where we can set a goal, that patients have it reviewed so it's like clear what is it that you're wanting to get out of your birth and the main things from your birth plan. I know I have had some struggle, and depending on the person, there's people who kind of print something off, and when you ask them about the specific things, they don't necessarily articulate it, and then others who it's very clear this is what their desires are. But I think that one of the improvements we really hope to get is that before patients are coming in, that some of that discussion has happened in the office. And then really kind of incorporating things into that prenatal care and documentation. And so with the program, having some part of that, visit, that care, that the doula who, if we've made this connection, that we can kind of summarize this care, have it be represented in their patient's chart, and then really kind of brought forward from that outpatient setting into the hospitalization. I think that acknowledgement of that prenatal care provider, kind of that connection, I think it does, I will say in my experience previously in putting in a doula program in the community, bringing it into the hospital, that has been a critical link where that connection being made, that recognition, it's almost like people are more respectful of their colleagues' words, which is, it's not how it should be. But I think that is a step, right? When you have that acknowledgement of the birth plan in the antepartum period, that bringing it forward into the labor and delivery. And then the next step is really acknowledgement on admission for labor and delivery of, here is what, not just that I've read it, because you could have read it and kind of, if you're poo-pooing the whole thing, then that's even worse that you're saying that you've read it and you're ignoring it. So thank you for bringing that forward. And I think, really when we're looking at how are we doing, having some regular feedback, I think is super important.
To build on what you're saying, I think that birth plans, as they have been traditionally done, are inadequate instruments to convey what somebody is aiming for in terms of, their communication, the atmosphere they're trying to create. They don't think about, I want this atmosphere, right? This is what I want patience with, like for my body to do things when like the vocabulary isn't there in a usual birth plan. And so it may be something, there is something that like maybe on the part of the staff, when you're able to like address it, there's something intentional, a group called intentional birth. And they advocate something called like a new, it's like a value-based birth plan. So rather than say, I don't want like continuous fetal monitoring, they say, I want to be part of the conversation, or I want you to be patient with my body. I want a physiologic birth. And so sometimes, like if your staff becomes more versed in that language, they may be able to interpret people's birth plans, and that like reduces trauma because people feel like they actually are heard, because if they didn't have the language, like somebody pushes back and says, oh, do you mean this? Right. And so the group was in, well, I heard them a couple of times speak. I think we call it intentional birth, but it was a value-based birth plan. It was really like a new idea to me, and it seemed to solve a lot of problems. Right. But it was like, what is the staff's values? What are, so it to match it all up.
That's wonderful. Thank you for sharing. Another piece is that residents, connection with the residents. I think that having doulas who are known entities with the residents, the goal and the ideal is that we kind of create more communication across kind of roles, so that when you're seeing, and this may be hard to imagine, but I'm telling you, 200 births in a tiny little hospital with 13 residents a year. And we've gone from when, the patient is on labor and delivery and we're doing safety rounds, I say they have a doula, going the sigh and the little snide comments, to the, oh my gosh, this is so great. Or the emergency phone calls, like, is there any way that we can get a doula for this patient? Like, that's the level of advocacy that we're going for. And I've seen it happen. I've been a part of facilitating that. And I think that having the residents really be the strong advocates for this doula support is really helpful. And it happens by increasing that communication. And so at some point likely in the summer, we'll be doing some kind of interactive session, and I'll invite all of you as well, just again to bring things forward to the residents to understand, what a doula is doing. There's not a reason to be intimidated. Again, we go back to the stats, we're at the bottom. The only place to go is up. So I think that that's just a really important thing, again, working from a space of humility to know that, like, there's nowhere where this is going well. And if we all are grounded in really wanting to provide care and support for families, then how can we work together to achieve that? And I think that we're going to do great things together. So hopefully you believe that as well. And I think all of you who are here, we will have your emails because you registered for the Zoom. We'll send out the recording and also slides as a PDF that makes the most sense, just so that the size works. And we'll keep you on the list for updates for the program. And if you have, like I said, if you have applied but not heard anything from either of the positions, if you could just send me a quick message, even in the Zoom chat is fine. Yeah, so I'll stick around if there's any other questions or any other comments. But yeah, and then quickly, did anybody go to the community baby shower that was during Black Maternal Health Week?
Yes, I did.
Any feedback, comments, thoughts?
I thought it was fabulous. It was so well organized. You got to see a lot of the community workers all under one roof. So I appreciated that. I would love for it to happen again in the future.
Awesome. Well, the goal is, if we can get everything up and running, it will not be at that size and scale. But if we can get to a place where this is something that's happening quarterly. And so then again, like if we're saying, well, program participants as a focal thing, and saying if you're breaking the year up into quarters, you say people with due dates from January to April, when is the community baby shower? And really kind of, again, like that level of support. And there was so much excitement from the maternity center staff. And there, as there is about the doula program, I'm not in a setting where it's like fighting and they don't want this. It's like, we want this, we want this. How can we help? How can we be supportive? You know, where are the, you know, who else needs to know about it? Those kinds of things. And so I think everyone here can help to spread the word as far as any kind of community organization that you're in, or even if you have clients who reach out to you, but they're going to be delivering at UMass and maybe they don't know how they're going to pay for their doula package, you know, filling out that web form. And yeah, so that's all I have. Thank you so much for your time. I will still stick around for questions if they come up.